Respected Chairperson of this session, expert panelists, and learned participants, Assalamu alaikum and very good afternoon. I am Dr. Muhammad Atikur Rahman, would like to present case entitling A Silly Matter May Impact a Lot. So this is my case, a 59 years old male, a case of non-STMI, who was planned for CAG plus minus revascularization. And this is the short history. Patient was normotensive, diabetic, and smoker. All vitals were normal. ECG was normal, as well as the echo with LVEF 60%. This is the audiocaudal view showing normal left main with 90% lesion in the principal vein. Also critical lesion in ramus intermedius. And epicranial view also showing the same. Aurocranial view showing 50 to 60% lesion in proximal LED and 90% lesion in principal vein. And allocranial view, LED lesion seems to be a bit non-critical, with critical lesion in principal vein as well. So the alliocaudal view showing normal left main as well as proximal LCX and LED with critical lesion in ramus intermedius. On the right side, allio and allocranial view showing RCA is ectatic with critical lesion in distal PLB. So this is essentially a TVD, but what should be the revascularization strategy? We decided to stent the WEM and keep the other lesion on optimum medical therapy. We took 3.5 curve EBU catheter, 5 French, and run through floppy wire that was advanced up to the distal part of the target WEM vessel. And pre-balloon was done with 2 into 12 millimeter NCU4A, and that was very smoothly done. Balloon was in progress, and we took 2.5 into 22 millimeter DES, but the stent was, we feel resistance in very initial step of the stent advancement. And we took cine whether there was any kinking in the catheter, but there was no kinking. We took the stent out and take a cine, but the vessel was showing very smooth lumen. So we are in dilemma. What was the reason? Is that the wire or the catheter that prevent the advancement of the stent? And then we changed the wire, took another wire with a strong shaft that was all-star floppy wire, but again the stent was struck on the same area. Then what might be the reason? Then finally, we take the catheter out and take a cine, and the vessel was also patent. So what might be the reason and what to do? And this is the catheter that was pulled out, and you can see there is a kinking. There is kinking here and kink there, and photos from different angle will describe it. And for your kind information, it was a brand new catheter, but it was kinked in its middle part. After changing the catheter, we proceed with another stent because that stent was stuck in the lesion, and that was 2.5 into 26 millimeter. And we succeeded to place the stent in the target area and deploy the stent, and we did the post balloon. And as the time was very long, the patient was become restless. Everybody was anxious, and we took 2 post balloon. One is 2.75 quantum apex, 2.75 12 millimeter, and another Wilma 3 into 10. As we are running short of time, so I will skip some slide. And this is the final picture. Though The result was not completely satisfactory, but I think it is acceptable. So I have a very short take-home message. Every hardware should be checked well before introducing inside the patient's body, whether it's new or used. Thank you very much for your patience hearing.